I'm absolutely delighted to launch our Breaking Boundaries series in AI in healthcare. So this has been by the generous support of UCD Research. So today we're kicking off with women's health and a startling reality. Well, for me as a woman, a startling reality is that women spend 25% more of their time in ill or poor health than men. So much of this gap, we believe, is preventable. And if we had better diagnosis, earlier screening, and I suppose more personalised care for women, I think we would really bridge that gap. And I do believe that we're starting to have the data, the technology, and the scientific understanding to change this. And I think our wonderful speaker and panel today will really demonstrate this. And I'm personally very excited to have this conversation today, and we're going to just get straight into it. So today's event, we're going to have a keynote by Professor Linda May, and this will be followed by a panel discussion. So Linda is a tenured professor at East Carolina University, which is in North Carolina. She is in the Department of Kinesiology for Health and Human Performance, as well as is an adjunct professor at the Obstetrics and Gynecology Department for the Brody School of Medicine in ECU. Linda is director of the Human Performance Lab at ECU, and she's also chair and co-founder of the American College of Sports Medicine Pregnancy and Postpartum Special Interest Group, and co-chair of the Physical Activity in Pregnancy and Postpartum Special Interest Group, as well as for the European Congress of Sports Science. She actively promotes physical activity during and after pregnancy for improved maternal, placental, and child health. Linda's keynote, it's the future is fit, data analytics to map the intergenerational benefits of prenatal exercise. And Linda, you are most welcome to UCD. Thank you so much.
Super excited to be here, my first time in Ireland. So I don't know if I'm more excited about my topic or about being here, but I just really appreciate the invitation. And thank you for the intro. So first, I'll start out with conflicts of interest. I have no conflicts to disclose, and hopefully by the end of this presentation, you'll be able to explain the influence of exercise during pregnancy on maternal, placental, and offspring outcomes. I have other outcomes, but again, I'm short on time, so I'm not going to talk about the nutrition and other things. It's just going to be like the tippy tip of the iceberg of what we found. And to get started, we know that the public health issue is this intergenerational cycle of obesity, right? And it's worldwide, although Americans are definitely fluffy, I will give us that. But we start out being pregnant, congratulations, but she's already obese or diabetic once she finds out that she's pregnant, and then that is going to expose the baby to that type of environment, and I'll get to that in a second on what we call that, but it's going to start earlier and be more severe because of this intergenerational cycle. And so worldwide map, we're going to have females on the left, males on the right, and you can see a low prevalence of obesity. But as I click through the animations, you're going to see we walk through from 1975 until closer to current times. You can see this darkening of the world map, right? And we're very dark red here because we have increased prevalence of obesity at a young age. These are 5-year-olds. And we know this is important because this adult obesity and childhood obesity are highly associated, right? And so they're starting obesity earlier and having it more severe. So now I'm going to get to this idea of prenatal programming, or the developmental origins of health and disease. And if you haven't heard of the term, you're familiar with the idea, right? And so again, congratulations, you're pregnant, but once she finds out she's pregnant, if she's already obese or diabetic, then it is what it is. Okay, so that environment now changes the mom, which then influences the way the placenta develops, which then influences the way the baby's organs are developing. And so now when the baby's born, it's highly likely to then have that condition because of that exposure, or it's programmed, right? But rather than programming this child towards disease, we like to talk about awesome things like good nutrition, and today I'm going to focus on exercise. So can we use exercise to make super babies rather than our fat, fluffy babies? Okay, and if you can see on the baby's onesie, I'm leaning into this AI, which is awesome. It made the onesie which says FitV. And so in my world, those metrics are going to be frequency, intensity, time, type, and then altogether that's volume. And so we use those metrics of exercise. And so briefly what we do is we recruit pregnant women, and so, reproductive age, and they're in that first trimester of pregnancy. In general, we'll recruit about anybody, but we do exclude a few meds and definitely no smokers in our population. And so all of the results that I'm presenting are based on this intervention, and the recommended guidelines really worldwide, but also in the US, is going to be 150 minutes of moderate intensity exercise every week until we have a baby. Okay, and we are going to randomize them, or we do randomize them into aerobic only, a resistance or strength only, or a combination of both of them, all of those groups at 150 minutes compared to a control group. So then we recruit them, and if you're not familiar, pregnancy is going to be 40 weeks. We want to get them at least to 37, as we talked about previously. So we recruit them in the first trimester. We do baseline measurements. I hope they don't feel like guinea pigs, but we poke and prod and do lots of things on them and get blood and measurements. And then, of course, we have a clearance letter. Then we continue to get measurements, but from the very beginning, we randomize them to one of those 4 groups: aerobic only, strength only, a combination, or a control. And then again, we keep training them, and they're like, when do I stop? I'm like, until we see a baby, you keep going. Okay. And then once they deliver, we get the placenta, the cord blood. I'll mention a little bit of that. And then we have mom and baby come back at 1, 6, and 12 months. And you'll see I have data for later. We have a continuation study to follow them up to 13 years of age, but I'm only presenting up to 7 years today. So let's start out with maternal outcomes. What does mama benefit from this exercise? Ooh, and in a lot of the corners, you're going to see my trainees who really led this data when they were working with me. All of them are faculty now. They're fabulous and amazing. But Cody led the omics. So what type of omic signature do they get, or do they even get a different omic signature in response to this exercise exposure? And so interestingly enough, when we ran the maternal blood, because of that exercise exposure, we have different phenotypes here. So different metabolomic signatures because of that exercise during pregnancy. And so you'll see control is separate from aerobic, and interestingly enough, resistance and that combination overlap a little bit, which is cool. But they do have different signatures. So aerobic, for example, again, just a tippy tip of the iceberg, because there's tons of data here. Triglyceride metabolism is changed, so they have lower triglycerides and lipids, lower glucose, for example. Whereas the resistance or the strength only increases in arachidonic linoleic acid. So those are going to be their polyunsaturated fatty acids associated with anti-inflammation. And then you'll see the combination group of aerobic and resistance combined really is a combination of those metabolomic pathways or signatures. And so that's really cool. I also like to mention the cardiometabolic risk score. This is a composite score of 6 different measures. Cardiologists usually use it to detect if somebody has an increased or decreased risk of cardiometabolic disease in their future. And as we know, pregnancy is a physiological stressor that we were talking about previously. And so as pregnancy progresses, because of this stressor, typically their cardiometabolic risk score increases, right? Because it's a stress. But guess what happens when they exercise to that cardiometabolic risk score? Any ideas? Right? So exercise is going to decrease that score, which is amazing. Related to the metabolism also, metabolism is going to improve. So again, insulin, blood lipids, and there's a negative association with her volume. So her weekly exercise volume, the more that she does, the lower her lipids and glucose is going to be. And so that's cool. There is a dose response, I'll mention that, similar to her gestational weight gain. We want appropriate weight gain and not too much, which is common in the US. I know, shocker. So other maternal outcomes related to the cardiovascular system, we see improved heart rate variability, so control of the autonomic nervous system on the heart is improved when they exercise, and also her blood pressure. And interestingly enough, these are really driven greater outcomes, greater benefit if she does that resistance or strength only type of exercise. And again, dose response. So we see a dose response in these maternal outcomes, and I think that's really important messaging for the gals, right? Because sometimes they'll ask you, so what's the minimum I need to do? Like, if you do a little bit, you get a little bit of benefit. But if you do more, you're going to get more benefit. And they're like, what's the minimum? Okay. A lot of gals want to ask about sleep, and so we did that analysis as well, right? Because they never get enough sleep, definitely after baby. But during the pregnancy, 15 or 30 more minutes per night, right? And so most of the gals are like 30 minutes. I'm like, would you rather have 30 minutes more or 30 minutes less, right? And so the exercise, they're going to sleep longer if they exercise during pregnancy. Again, driven by doing aerobic only or resistance only exercise. Quality wasn't necessarily specific to type of exercise, but there was an increased probability of having improved sleep quality if they did exercise during pregnancy. So somewhat of a paradox. And I know I talked about the virtual sessions. Yes, it's better if they do supervised exercise because we're watching them and we're like, I see what you're doing. Come on, work harder. But virtual is also an option, right? And it definitely helps us to reach to more people for sure. So supervised is better than virtual, but again, it's dose response. So something is better than nothing, right? So that was a little bit of mama outcomes. Now, ta-da, we have a baby, but I want to talk about the placenta first. In case you haven't seen one, that's a placenta. So how does the placenta benefit? And this is important, right? Because that's the exchange organ, nutrients from mom to baby. So this is important to look at. When we stratify by exercise type, we see that when we evaluate the metrics, interestingly enough, regardless of the exercise type, that dose is going to increase the placental diameter. More exchange between mom and baby. That's awesome. That's my clinical term. When we look at resistance only exercise is going to predict and drive improvements in the placental weight and density. It's going to predict a greater diameter placenta. Okay, so again, very cool. We see placental efficiency by volume is increased specifically by resistance only exercise. Then when we look at aerobic exercise only, it's going to predict placental efficiency by weight. So a little bit different physiological system going on here that we need to analyze a little bit more. All right, so that was a little bit about placenta and the exchange organ. Now I want to transition to baby. And yes, we have a whole baby here, so we can do measurements on baby. But I do want to remind you, can you see that? Oh, you can't see my mouse, no worries. The cord is right here, and the cord will have stem cells from baby. So we can also look at baby's cellular outcomes as well as whole body outcomes. And so I'll talk about both. But let's do whole body outcomes first. So for full-term babies, it's going to normalize that birth weight, right? We don't want macrosomic big babies, and we don't want low birth weight babies either. We want them right in that nice happy zone, and that's what exercise does. It helps normalize their birth weight, which is important. It does change that ponderal index that's seen with combination exercise. And now I'm going to start to transition a little bit into the overweight, obese women. Similar to that prenatal programming, healthy weight women program their babies to be what? Healthy weight, right? And so we don't have too much room of improvement. We're like, you're already doing great, keep it up, right? But the overweight, obese women typically program their babies to be overweight or obese. So that's where we need to focus on. And so when we were looking at our data, we see that the healthy women are really diluting our effect, right? Because there's not much room for improvement. And so moving forward, I'm really going to focus on these women who are overweight and obese to see if we're actually programming their babies to be healthier. And so, for example, the overweight, obese women, if they exercise in pregnancy, have decreased risk of C-sections rather than an increase, which is typical. And this is also exciting. In the U.S., a lot of our black women and minorities in the U.S. have an increased rate of preterm birth and low birth weight. But when we exercise them, we're decreasing, we're attenuating this racial disparity. We can get these babies to full term, which is amazing. And even more amazing, if the babies are born preterm and they're from a black woman, for example, the baby is more mature and released as a full-term baby, right? Because the exercise matures that whole system. And so I was like, dang, that's awesome. Give them a good pair of shoes and we can decrease preterm birth rates. So again, there is a dose response. We can see increased frequency per week is going to increase that baby's nervous system maturation, which is important. Also increasing her intensity. So rather than low, we do a moderate intensity or a moderate high intensity. That's going to get baby closer to that estimated due date. Again, we want babies to be born healthy and on time. Fully cooked is good. And similar to exercise dose, we want to increase that weekly exercise volume as a whole because that's going to decrease their hospital stay. So again, even if they're preterm, they're more mature, and so they're released at like a full-term baby, okay? Excellent outcomes. All right, so that was whole body outcomes. Now we're going to go back to this stem cell, and we can look at that mesenchymal stem cells to get an idea on baby's cellular outcomes. And so the mesenchymal stem cells, again, they can differentiate into multiple cell lines, but from a metabolic perspective and energy metabolism, we want to focus on the undifferentiated stem cells, and then we also want to focus on the myogenic line. So an example of the baby's skeletal muscle, without taking a biopsy, because that would be mean. Doing a skeletal muscle biopsy from a baby, come on. No IRB would approve that. So we differentiate the cell into a myogenic line for skeletal muscle and then an adipogenic line for fat cells. So those are the two metabolic extremes that we want to look at for baby. Okay. And then my postdoc and my previous PhD student ran these so that we can get an idea on cellular respiration. So respiration of the baby at the cell level. And what we found is that all of these babies exposed to exercise had an increased respiration at the cellular level. And interestingly enough, it was a stair step. We have controls, then we had aerobic exposed babies, then we have combination exposed babies, and then we have resistance only exposed babies. So there was definitely a difference based on the exercise type a baby was exposed to in utero. We also saw improvements in insulin sensitivity. So rather than these babies being more likely to be diabetic, for example, their cells are insulin sensitive, which is great. And again, this was at the undifferentiated cells, the myogenic line and the adipogenic line. We saw all of these, okay? And even less lipids in the adipogenic line, so very exciting. But what about the whole baby outcomes? This is our baby astronaut. So when we do our resting metabolic rate for the whole body respirations, we can compare this to our cellular outcomes. And yes, baby has an increased whole body respiration, which maps with what we see at the cellular level. And then we also do DEXAs on babies because we have the myogenic and the adipogenic cells. We wanted to see what's happening with the baby at the whole body level. And what we see is that baby not only has decreased body fat, which maps with the cells, but increased lean mass, especially if they're from what group? Resistance. Thank you. Thank you for that participation. Okay, so that was the birth outcomes. Now we want to move to 1 month. For an exercise response, usually 4 weeks is enough for a washout period. So we want to see at 1 month, do we still see some of these outcomes? Are they actually programmed or is it washed out because they're not exposed in utero anymore? So I'll start with the omic signature. Ta-da! Look familiar? Similar to what we saw with the moms, we see 4 distinct metabolomic signatures. And interestingly enough, we have controls and aerobic and a little bit of crossover in that combination and resistance group, similar to what we saw with the mamas. And again, we have tons of data that we're still analyzing. So this is for any type of exercise. We see baby's blood at 1 month of age. This metabolomic signature has increased ATP, and protein metabolism is all upregulated, and things like gluconeogenesis. So very exciting from a metabolic perspective for babies exposed to exercise in utero. And even more interestingly enough, the downregulated metabolites were pain, inflammation, and tumor and cancer. And I wasn't expecting that, but that tracks with decreasing that load of obesity and diabetes, right? Because those are inflammatory conditions. Currently, she's a faculty member now, but Bree, when she was my PhD student, also wanted to take this one step further from the metabolomic signature and then go a little bit into the proteins. So now we're going to talk about the proteomics, but briefly, because I don't have lots of time. And so she compared the aerobic to control, the resistance to control, and the combination to control. And what we see is a downregulation of the inflammation and improved immune response, which is cool. And again, I'm going to go through it kind of quickly, but interestingly enough, we can see that combination group has some of this crossover from aerobic. Then it has some of the pathways for the resistance, and then a few extra. So there is this interesting type response that's different for the baby depending on what it was exposed to in utero. But to summarize her outcomes, any type of exercise was beneficial, a few that were very specific, but all of them are going to decrease that inflammatory pathways. The combination exercise did predict babies' lower interleukin-6 and lower cortisol levels at 1 month of age. And again, that dose response was important, right? So increased total volume across pregnancy is going to predict some of those lower interleukin markers in baby at 1 month. But again, I still want to highlight that there is a difference based on mom's BMI. So really, we have to take out the normal healthy weight women and focus on those overweight, obese women. And as a case in point, I wanted to come back to this cardiometabolic risk score because it's a composite score, so it's a little bit more sensitive, especially for babies. And so you can see in these healthy weight, or babies from healthy weight women, aerobic only, resistance only, in combination, you can see any type of exercise decreases the baby at 1 month of age, decreases their cardiometabolic risk score compared to an average baby who's not exposed to anything, right? Just standard of care. So that's cool. Lower cardiometabolic risk score already at 1 month of age. But then when we look at the babies from overweight and obese women, what? Any type of exercise is good, but what's the best one? Resistance or strength only, right? If they're from moms that are overweight or obese. So then, again, to conglomerate and condense my time, because I'm running out, we want to look at their lipids, their BMI, their body fat, for example, lean mass, resting metabolic rate, cardiometabolic risk score, and motor skills. Will be compared, and this is overweight, obese, babies from overweight, obese women, we'll compare them to the control group. So we see some improvements in just about all of these outcomes. If they're exposed to aerobic exercise in utero, no real changes in lean mass, but what do you think happens with the resistance-only group? Even better, right? All of those outcomes were improved with an increase in lean mass. So from a metabolic perspective, that's metabolically active tissue, and that's really important. And then combination fell in between those two. And again, wanted to follow up with that cardiometabolic risk score, but a lot of our outcomes are very similar. There's going to be a dose response. So based on her weekly, for example, intensity, more intensity that she did each week, improved outcomes, right? So lower BMI, lower body fat, for example. So it was similar for her intensity, frequency, and duration each week, and then of course that total volume across the pregnancy. All right, and then what happens as the kids get older? Are they still programmed? Do we still see these improved outcomes? And so Kara looked at this trajectory. These are motor skills, because I think that's cool. She loved to play with babies. And so motor skills at 1, 6, and 12 months of age, you can see the control babies in that bottom green line. That's where most babies fall, at that 50th percentile, right in the middle is where most babies fall. But you can see at 1, 6, and 12 months, any type of exercise that they were exposed to in utero had an improved motor skill still at 1, 6, and 12 months. And definitely for that combination resistance group, they were still definitely better. And again, more focused on the overweight, obese women if they did the resistance exercise. So as babies get older at 6 months, do we still see improved outcomes? What do you think? Yes, because I'm still talking. So lower body fat and BMI, increased lean mass, lower glucose levels at 12 months of age. Yes, we still see the same thing. Lower lipids, glucose, body fat, and BMI. And then even at 1 to 7 months of age, we see this similar outcomes, a little bit less data, because it takes a long time to get these babies to 7 years of age. Right, because it's like a whole year of pregnancy and then 7 years afterwards. Oh, I better shut up soon. Okay, I will wrap it up. And improved heart health outcomes. I am wrapping up, I promise. But for these babies that are from overweight or obese women, guess what drives their outcomes? Very interesting. Right, so hopefully this isn't you guys. So improved outcomes, yes, birth to 7 years, frequency, intensity, type, and her volume of exercise that babies were exposed to in utero is important. Placental health, yes, it's driven by these changes as well. Maternal health, intensity. Again, if she's overweight or obese, we should be thinking of what type of exercise? Yeah, it's great to go for a walk, but that resistance training is really important. So healthy programming beyond? Probably, right? All right. Always want to acknowledge, I will collaborate with anybody interested in this topic. So people at ECU, people across the US, people all over the world, if you love it, I love it. I'm supported by NIH, by American Heart Association, Blue Cross Blue Shield, Thrasher, AAUW, and I always give kudos to Brooks Shoes. They give our gals free shoes, and I do love their shoes. And my team, I do not do this by myself. I sit in my office and write grants now and publications. So my team does all the fabulous work. So yeah, let me know if you guys have questions. We're gonna save them for later.
Have a quick discussion and then we'll open it to the audience because I'm sure you've a lot of questions for Linda, but you will have a lot of questions for our panel too. And if it's, we usually leave people, I suppose, wanting more after these. So please, I'm delighted. So maybe I'll start with you, Fionnuala.
Well, thank you so much for the very kind invitation to come, and congratulations, Linda, on amazing research, really interesting. So I'm Fionnuala McAuliffe. I'm obstetrician gynecologist based at National Maternity Hospital and UCD, and I've been looking at nutrition and well-being exercise in pregnancy and across the life course for the last 20 years. So very excited to hear your work, and congratulations, amazing talk.
It's great, and I was just going to ask you first, maybe just you could comment on, and after hearing obviously Linda's talk, but from your expertise looking at pregnant women, especially around gestational diabetes, Where do you think, I suppose, the greatest opportunity lies? Maybe you might tailor that to what you just heard as well as your own experience.
Well, I think pregnancy is a really important time across the life course. So I'm delighted that for the first talk of this programme, we're looking at life course medicine, we're looking at our future health, our future generations. I mean, what more important area should we be focusing on? And pregnancy is a very unique time because it's the only time in the life course where you have two people, two patients. So anything you can do to improve health will improve health for both. So there's a fantastic opportunity there. And also women are very health seeking and very open to advice. So a lot of patients that I see, it's what I would call mañana. Well, that's fine, that advice, but maybe we'll talk about it tomorrow. But I think in pregnancy, they're very engaged and they really want to do better for their babies. So it's a really nice time to think about exercise and nutrition. And certainly you mentioned gestational diabetes, so that's quite common. It affects up to 20% of our mothers. And we know that, for example, healthy diet, low glycemic index diet and exercise actually reduces the chance of gestational diabetes. And we were talking earlier with Elva that if you get gestational diabetes in pregnancy, there's a 50% chance of type 2 diabetes later on. So if we could prevent gestational diabetes, and there's very robust data now on physical activity and good nutrition. In Holles Street in UCD, we have this longitudinal birth cohort called ROLO. So we recruited 700 women in early pregnancy and we randomised them to a low glycemic healthy diet. And we've had an opportunity to follow them now 10 years, 15 years. And that has allowed us to look at what happened to the women in pregnancy and their later life health. And as you alluded to, women that had a little bit more weight in pregnancy or higher sugars or higher blood pressure in pregnancy, 10 years later, then they're running into difficulties with diabetes, with hypertension. So there is that opportunity in pregnancy to, it gives a window to the future health. So if she has blood pressure in pregnancy, high chance she'll have blood pressure, cardiovascular disease later on. So we've been following these women and we've identified a couple of factors that can reduce those later life risks for chronic disease. So we know breastfeeding, for example, everyone knows it's good for the baby, but it actually reduces cardiovascular disease in the mother.
It's incredible.
It reduces diabetes in the mother, and we recently published and got a lot of media coverage, particularly from the States, that breastfeeding reduces mental health problems 10 years later. So breastfeeding is something we can advise women, and then of course maintaining a normal weight and exercise, of course, during and after pregnancy. So I think pregnancy is a really nice time to look at life course medicine and to look at chronic disease prevention.
Love it. Thank you so much for joining us, and I'm sure you're going to have a lot of questions as well. And maybe Kate, I'd move on to you as well. Maybe just quickly introduce yourself. You've got an incredible career.
Thanks. My name's Kate and I am a member of the Discipline of Sport and Exercise Science here at UCD. I'm an exercise physiologist and also a sports dietitian. So I've worked across academia for the last 20 years, but also in professional sport as a sports dietitian for the last 20 years as well. And then over the last sort of 3 years since I've been at UCD, I've also been dabbling in a little bit of entrepreneurship, and I've been developing wearable sensors to monitor and measure energy expenditure during exercise.
So Kate, you've worked, I mean, she's very humble because she's actually been exercise. You worked for Leinster Rugby, but also across Australia for the Wallabies, the Brumbies. I mean, you've had an incredible career. Women exercising and health. I mean, just from a personal perspective, I grew up as a dancer, and it was really, there was the skinnier you were, the better. Not having your period was almost a badge of honor. This is almost. It's what this is a long time ago, but what's the situation now, this idea of energy availability?
Yeah, so energy availability, for those who are aware of this in the room, is when you essentially don't eat enough food to meet the demands of normal everyday activities, plus if you're an athlete, all the training, competition and recovery that you need to experience as well. And so a lot of my work over the last few years has been trying to assess energy availability in a more objective manner, because at the moment, from some of the research that I've done across elite sport as well as in dance populations, which how we got sort of connected, was through athletes, and particularly female athletes, not consuming enough food because of those social pressures to look a certain way in aesthetic sports like dancing, but also in other sports that you would not traditionally associate with an aesthetic nature, such as rugby, where the girls are particularly focused on what they look like while they're performing as well. And often the first reaction to that is to train harder and to also reduce the amount of food that you're consuming to maintain that lean physique, where in fact that actually has an opposite effect. It disrupts our hormonal profiles, it reduces our bone mineral density, our lean mass. It also impacts mental health. Ultimately, for an athlete, it impacts their performance. And we see this trend progresses through life stages as well. So it's not only in an elite population. As women age, they perhaps put on a little bit more weight, particularly through menopause, perimenopause. They start to reduce, not everyone, but some will start to reduce their food intake to try and offset perhaps some of that fat mass gain, which is completely natural and normal. And then they start to retain that fat mass and suppress their metabolic rate rather than eating appropriately, resistance training. And I love that you have a big focus on resistance training, because I think it's so important for females to get in the gym and to lift, or even to be doing some form of resistance training at home to improve your muscle mass, improve your metabolic rate, and actually really, I guess, eat to thrive rather than just to survive.
Love it. Brian, I would love to come to you, please. Maybe you just introduce it. Most people maybe in our audience would know you, but maybe you could introduce yourself, please.
Yeah, so I'm Brian. I'm a professor of physiotherapy here in the School of Public Health, Physio Performance, or Sports Science, sorry. And also a PI in the Insight Centre for another couple of weeks until we transition to the RIN Centre for AI. Yeah. And my research is really all about using digital technologies to either better measure, understand, or enhance human performance. And we do that in a lot of different application spaces right across, elite sport, where we might be, looking at data from instrumental mouth guards to measure subconcussive impacts over the course of a season in rugby players, through to developing better methods for identifying falls in the elderly, or even predicting falls in the elderly, through to helping people understand their marathon training data. So it's right across the spectrum, health to sport.
And we've heard a lot about life course health and intergenerational health. So how can sensors help us? I'm sure it sounds like they could actually really help us understand that.
Yeah, well, the interesting thing is that sensors are kind of dumb. Sensors, now I know that there are people in the room here who develop sensors. All our research, we in the early part of my career, we looked at developing sensors, and we quickly moved on to using off-the-shelf sensors. I think there's a nice framework for thinking about how we can use, digital biomarkers to enhance human health. And it's this 3V framework, and it's verification, technical validation, and clinical validation. And verification is about, does the sensor measure what we think it's measuring? So is an accelerometer measuring acceleration properly? Technical validation is, can we measure the target biomedical variables? So if we're looking at acceleration data, are we accurately measuring steps, for example? Yeah. And then clinical validation is, well, is that telling us anything useful or interesting? And can we use that information to actually make a meaningful change in a person? And I think so that's why I say the sensor is kind of dumb. It produces the data. It's that service layer that we build around it. That's where the really interesting challenges are. And I think we're in an age now where we're making way more progress on that last V than we ever were before. The first 15 years of sensors being widely available was all about the first two Vs. And I think particularly with LLMs, it's really helping us. And I think anyone in the room who uses Strava will have seen in the last year the introduction of, some really interpretable, summaries of your exercise sessions. And that's where we're getting to that level now where we can start to truly help people. And I think in this particular context, there's maybe two really critical levels. And you spoke about the aerobic exercise, which is all about making people move in just any weight, it's going to burn energy. And then the strengthening, which is where we have to be a lot more targeted. And I think we can use data from sensors to influence people in both of those. We can, at that kind of macro level, we can use it to try and help people be more active and give them explainable recommendations around why they need to be, when they need to be more active, as opposed to just measuring it. And then on the resistance side, we're starting to see some really interesting examples, particularly because in resistance training, there's an awful lot more focus in recent years on intent-driven resistance training, and velocity-based training is very, very voguish. It's the idea that instead of just getting somebody to go out and lift a weight, you would say, okay, we're going to very much target what you do in terms of the intensity of the work, in terms of the resistance that you're working against, and the velocity, particularly velocity, has really come to the fore. How fast you lift it, how fast you let it down, etc. And sensors are really, really making a difference there, because you can actually, in the exercise session, help people be far more effective in how they actually execute their exercise session. And that's something, Output Sports, for example, yes. That's one of the key things that Output Sports has brought to the table, is that they measure, Output Sports is a single sensor-based offering that measures about 200 different kind of, target metrics. In athletes, but, the direction of travel is that it's in everybody. Yeah. Athletes is the point of entry. Yeah. They, like I say, they measure about 200 different things, but there's about 4 or 5 things that are used 90% of the time. Yeah. And one of the top ones is, barbell velocity. That would probably be their top measure. And athletes are using it during the training session as well as an outcome metric.
What I'm really curious, though, is as a normal person who's not an athlete, a full-time athlete, and maybe, our audience, their partners themselves, their family, their sisters. So I'm going to really focus on this lifelong health aspect. So I suppose just before we open it up to the audience, what's the one thing now that you're in your field, I suppose, distill one thing that you would tell them is the most important thing that they should do? I mean, should we be all getting a wearable, downloading Strava, lifting barbells, but in a very defined way, it seems? Like it's not just ad hoc.
Yeah, I think what I would say is that the key thing is it's not going to be the same answer for different people. It does, and it needs to be based on what your target is. If you're a person who is inactive and wants to change your lifestyle. But I think the other thing is, I would say, is to not think necessarily about the device, to think more about the services that are built around the device. I think particularly, and there's another area that's worth mentioning here, is that when it comes to the female population, this is yet another area where females are not as well served as men. And I think there are some service providers and companies that are probably doing a better job at developing services for women. Aura Health are really focusing on it. And I think that it's interesting. There's a program of work here led by Sinead Holden in UCD that is looking at what you might think is so glaringly obvious you can't believe it's true, that heart rate variability, in recent years heart rate variability has been a major kind of focus for people guiding their intent-based exercise. And it turns out that heart rate variability measurement in females is very much influenced by circulating ovarian hormones. So that you, on 2 different days in a given month, you may get a wildly different heart rate variability measure.
Just because you're at different stages of your cycle.
Purely got nothing to do with your exercise readiness. Yeah. But none of the services currently actually factor that in. They just literally give the measurement and people make their interpretation. So Sinead's work is all about trying to help women interpret their HRV measures.
Look, I'm going to go to Kate. So what's the one thing, suppose you'd like the audience to know?
I guess maybe I'll say one from an exercise perspective, which is the resistance training, but I think something is better than nothing, and the ACSM just put out their updated position stand on resistance training this year, and it really is, because there's so much in the media about lift heavy, you lift to failure, do endurance-based training, but a lot of it was you need to do something, and that it doesn't need to be fancy, and you don't need to have fancy equipment. For those of you who might be in the audience thinking, well, I'm not going to a gym to lift a barbell, like absolutely that could be very beneficial, but there's loads of other things you can do outside of that, as long as you are applying some resistance to your muscle in a meaningful way to make improvements. And I think perhaps from a nutrition perspective, something that's becoming more well researched in the female population is the consumption of creatine. So there's been maybe a little bit more controversial in depending on what your beliefs are, but typically females don't consume as much creatine in the diet as men do, and our diets are changing quite significantly. And there has been some really nice evidence in female populations looking at the consumption of creatine and cognitive function, mood, sleep, and also that helps with maintaining that muscle mass.
And dementia as well. So how many grams should we... This is a loaded question, because I want to know, because I take 5, but I don't know how many I should be taking.
I guess there's two different strategies.
Yeah.
You can do an acute load where you might have 20-25 grams a day split into doses across the day for sort of up to 7 days, and then drop back to a 5-gram dose. But somewhere between 5 and 10 grams seems to be the sweet spot on a daily basis.
Thank you. That was a totally loaded question. Fionnuala, please, just what's the one takeaway, I suppose, for our audience, just in case they've sisters or daughters or, who are currently pregnant or going to be in the future? What should we be thinking about?
Yeah, well, obviously I see a very different population to the ones that you see. Most of my pregnant women are, we struggle to get them with 150 minutes a week walking. So my advice would be, in terms of planning pregnancy or in pregnancy, maintain a normal body weight and keep active and healthy diet. So just simple things, but pregnancy is a time where you don't really need to increase your calorie that much, and maybe maintaining your weight in pregnancy is the best thing, plus exercise. So keep active. So my experience is that women who keep active have less blood pressure problems, diabetes, and they seem to recover from the birth better. So keeping active would be the one thing I'd be saying.
Amazing, thank you, Fionnuala. And Linda, please, we haven't heard from you on the panel yet, but so thank you for a beautiful, energetic talk. It was fantastic. But maybe just, I think you've already told us about resistance training, but is there anything you'd like to add to that from your experience? Because I think what's really intriguing is you're going to follow these children. And that, for me, is quite unique, actually, globally in the research field. So I suppose, what should we be thinking about? This is so profound.
Yes, ma'am. So yes, we're following the moms and the babies. Most of our older moms and babies, the babies are about 10-ish, 11-ish, 12-ish right now. So yes, ma'am, we are following them. And I think all the other panelists kind of hit the nail on the head, right? It's, every minute counts as far as exercise. A little bit more for the clinical application, precision medicine, I think is important. Healthy weight women, they're already programming their babies to be healthy weight, so really any type of exercise, as long as they're doing something, right, keep moving. But the overweight, obese women, we really need to lean into move something, right? And I tell them, I'm like, this is resistance training, right? So you don't need to go to a gym and do fancy things, right? You lift your body weight and move it in a functional way, and I think that's really important. But then lean into that, they need to eat. Right? They need to eat an appropriate amount of calories for them in that pregnancy. Nothing extra in that first trimester, but that second and third, they need a little bit more. And I always tell them, especially when baby's the size of a pea, I'm like, you're not eating twice as much, you're eating twice as healthy, right? And so it's really important to lean into the nutrition and, right, the exercise and nutrition, they're intermingled, and I think they're both really important. So briefly, it honestly depends, right? When you think of behavior modification, Fionnuala already mentioned it, right? Pregnancy is a special window, and so they're thinking not of themselves, they're thinking of what's best for baby, right? And so it's a special time where they will make those behavior modifications. Once baby's born, it's still all about baby, right? And baby's separate from them now, and so they don't always take care of themselves. And so honestly, it depends on where they fall on that stages of change, right? Some gals, they know that in order to take care of baby, they have to take care of themselves, right? And so they do continue that behavior modification. But in the US, we have plenty that are in the, pre-contemplation, contemplation portion of that stages of change, and they do not continue that, right? And so I've had plenty of gals in the US, they're like, oh, I'm pregnant again because I'm enrolling in your study because that's the only time I work out. And I'm like, oh, I want you to keep doing it away from me, right? And so, yeah, sometimes it's only in pregnancy when they make that change because it's all about baby. So it honestly depends on where they fall on that stages of change. And I wish I could say it was everybody, but they're human.
If anybody else would like to comment on that, Vanilla?
Yeah, I mean, I think you've made a great point. So when we see them in pregnancy, they're very open to advice. And the Irish government has a chronic disease prevention programme and is one of the few countries in the world that offers annual checks to women after gestational diabetes and blood pressure problems in pregnancy that is funded. So we're capturing these women in maternity hospital and advising them to attend their doctor, which is funded by the government every year for a full health check. And we've instigated a FIGO pregnancy passport where we give them a little document that tells them they're at risk of the following problems: cardiovascular disease, this is what they need to do to reduce it, exercise, normal body weight, breastfeeding, and then they should have annual checks on what needs to happen at those checks. And then they're bringing that to their GP, who then can look at this and say, well, you're at risk, etc. So I think you use the word moving the dial a little bit. I think we are, and I think we're capturing them in pregnancy. And the challenge now is to keep them engaged before they end up in your services.
So the question's related to the child's teeth afterwards, and I do have a collaborator in the dental school who's looking at that, and we have at least one publication on that where their health conscientiousness, right? If they're more likely to engage in the exercise and the good nutrition during pregnancy, that health conscientiousness, then they're more likely to transfer that over to baby and carry on those good habits for themselves and for baby. And so there is an association actually with their health conscientiousness during pregnancy, after they deliver, and then baby's teeth. But yeah, so it's interesting you asked that, but yeah, we have looked at that. Preconception. Yeah. So it's kind of mixed. Actually, we do have data that we're collecting on, whether they've conceived naturally or, IVF and artificial means. We haven't analyzed it yet. We have tons of data. If anybody wants to analyze data, we have tons.
Brian Markney's
Email me. Oh my gosh. Email me.
I'll get you in contact.
Email me. So yeah, we haven't looked at that data yet, but I know previously when they looked at interventions pre-conception, it wasn't as effective as during the pregnancy, which makes sense, right? Because during pregnancy, that's when that physiological stressor is, that's when baby's organs, that's when the placenta is developing, right? That's the critical time to positively influence things. So yes, it's always better to, be healthier before, of course, right? But the critical time when everything's forming and developing is pregnancy window. And so it seems like that really drives changes, which is good messaging, honestly, because in the US, like I mentioned in that prenatal programming slide, in the US, they're like, congratulations, you're pregnant. And they're like, I'm already fat, right? And so they're like, we can't change that. And we're like, no worries. This is the time to make those positive changes now. So don't worry about what you didn't do before. We're going to focus on right now and move forward. And so I think that's really good messaging too.
I think Kate wants to come in and then we might just wrap up.
I was just going to say, it's really nice that they have a GP or a checkup 12 months after birth. And Australia has a different healthcare system, I guess, to here, but leaning to your response, if in Australia, if you were perhaps planning to become pregnant and you were overweight or obese, you'd be eligible for up to 5 clinical exercise physiology visits for free. So the government would pay for you to go and see an exercise physiologist to get a tailored exercise program, and you're able to receive 5 free ones every year. You can obviously pay for more, but that's something that does happen, and that goes across all the chronic diseases. There is a really nice public health service. It's covered by Medicare and insurance in Australia for those clinical exercise physiology services, which we don't quite have here yet, unfortunately.
But we will. There's people in the audience that can make that happen. So I just want to thank our wonderful speakers and panel.